Well, thanks for joining us. This, I think, is our fourth session. We had a wonderful session last week that Elizabeth hosted along with David Shane. So we have a special guest this morning. Eoin O'Sullivan is actually part of the UH Advanced Center's advisory committee as well. So we have a panel of diagnosticians who are clinicians involved in various aspects of diagnosis. And Eoin is a clinician himself, but his actual role is to be an external advisor to our center as well. He is an academic nephrologist. As you can tell by his name, he's probably originally from Ireland, and he has worked there. But he also worked at the University of Edinburgh in Scotland, and is now based in the beautiful city of Brisbane, Australia, where I'm sure it's going to be a nice, hot summer day tomorrow, because it's 10:30 at night for him. So I really want to thank him for joining us. So Eoin's interest is actually in computational biology and understanding senescence in particular. But like me, he has a strong background in medical education and has been interested in how cognitive bias leads to diagnostic error. And this is something I've been interested in as well. And he's found, as have many folks, that despite clinical experience and training, cognitive bias is fairly universal to everyone. So thank you for joining us, Eoin, this morning.
Yeah, thanks very much for having me. Lovely to join you.
Okay, so I'm going to start us off with a few questions. Let me see if we can do this. There we go. Okay, and there we go. And I don't know why, Elizabeth, you're being spotlighted, but let me change that here.
Luck of the draw.
Yeah, there we go. I'm going to remove your spotlight for a second. Okay, remove spotlight. There we go. Okay, now we're good. All right, thank you all. So I wanted to start us off by perhaps speaking about diagnostic error in general. We know that it has a number of root causes. Can you comment generally about the role of cognitive bias as a cause of diagnostic error?
Yeah, absolutely. So, I mean, I think everyone here understands the importance of diagnostic error. So I'm not going to kind of rehash all the statistics that you're, intimately familiar with. Before we kind of talk, I guess, about cognitive bias, it's worth just clarifying what we're actually talking about. So what is cognitive bias? Cognitive bias is when your thoughts, despite you thinking you're doing a great job, your thoughts lead you astray and make you misinterpret data or act irrationally. And it's not because you're being silly, it's not because you're misreading something, it's because the actual machinery of the thinking, the way in which you're approaching and the way in which you're processing the data leads you to the incorrect conclusions. So that's a cognitive bias. It's to do with the hardware and of the thinking, so to speak. And later on, as we're probably going to talk about some of the ways we can modulate this and think about this, but it's worth maybe just taking a few minutes just to reflect on where this actually comes from, because it helps to kind of contextualize things in a minute. So people tend to think nowadays in terms of the way in which we approach problems. They tend to think of the way in which we process in two buckets, this kind of type 1 thinking and this type 2 thinking. And I'm sure many of you will have encountered this in your various readings, but just as a refresher, type 1 thinking is what we spend most of our day doing, 80–90% of the day. And it's this very fast, intuitive style of thinking. And it's based on pattern recognition and efficiency and this ease of cognitive burden. So if you're going around on a ward as a clinician and you're quite experienced, you might be looking at an X-ray, and within a couple of seconds, you're comfortable it's a normal X-ray and you move on. And that wasn't a particularly taxing task for you. You might look at an ECG and have a similarly easy time. And that's because, you're quite good at your job now. You've refined your sort of pattern recognition skills. You're in type 1 thinking, you're shooting from the hip. And this is a really good way to go about quite a big chunk of your day, because not too burdensome, fast, efficient, and it's the kind of the default state that we're in. And this would have had probably a lot of advantages back in the day, because if you see a stick that looks a bit like a snake, I'm in Australia now and have to think about these things, you're going to jump away and have a bit of a startle moment. you're not going to sit there and deliberate. Is that really a stick? Is that a snake? You just bang, reflex. But you can see how that could lead you astray in the clinical world. These reflexes can be misleading. And then type 2, in contrast, is this much more deliberative, taxing, brow furrowing way to think about clinical problems. It's when you sit down with a cup of coffee and mull over something, or knock on your colleague's door and share the case. And type 2 thinking, it's hard. It's hard work, takes ages. It's clearly not the kind of thing you can do for every single case. You get nothing done. But type 2 thinking is where you tend to avoid bias. You tend to minimize it, to debias yourself. So circling all the way back around to your question, what's the role of cognitive bias? Cognitive bias is what we've just described, and it's common. The problem with it is that it's hard to measure. So the estimates, rather than the facts, the estimates are that cognitive bias is probably found in all parts of the diagnostic pathway. Certainly it's been recorded as such. So that's both data interpretation, assimilating and thinking about it, formulating plans and communicating with patients. There's huge scope for mistakes and missteps there. In terms of raw percentages, there's a couple of interesting papers where clinicians look back and reflect on their and others' work, and the most conservative estimates tend to be sort of 10 to 15% of diagnostic errors involve cognitive bias, but it climbs very high when the errors start to involve human interaction. So if it's simply looking at x-rays or interpreting bloods, you can get it down to about 15, but by the time you're taking a history from a person, which unfortunately is bread and butter medicine, you can have like half of the mistakes are due to some sort of cognitive bias. So it's common, it's everywhere, and it's linked in a large part to the ways in which we think, which kind of give us a bit of a framework to talk about it and how we can avoid it.
Yeah, thank you. And that was a great setup for some of our follow-up questions here. So, in reading about this myself, I know that Pat Croskery, for example, has a number of papers talking about different types of cognitive bias, and Elstein and Schwartz going back a ways. Can you describe some of the most common categories or common types of cognitive bias clinicians are prone to?
So I'll certainly give you some of the ones I think are most common, but actually you've touched on a real deficit in the literature here, which is that Pat Croskery is this fantastic sort of thought leader in the field, and he's cataloged hundreds of these things. But actually, we don't really know which are the most common, because we don't really have a systematic way to pick through all of the diagnostic errors yet. So we don't know which are the most common. We don't really know which are the most clinically impactful. We have our own intuitions about this, but I suspect it's going to be different in the field. 3 that are worth sharing, even as illustrations, but I think they're quite important. The first would be, I guess, search satisfying, and this is probably quite familiar to many of us. This is really important, I think, for radiologists. They kind of talk about this quite a lot, but search satisfying is kind of what it says in the tin. You're searching for something, you find it, and you are prematurely satisfied. So you can imagine yourself looking at an x-ray of a chest x-ray or some broken bones or what have you, and as soon as you find an abnormality, there's a tendency, and this is demonstrated time and again, there's a tendency to stop. And you get a hit of dopamine, that rush of satisfaction, high fives all around, ready to move on. Yet contralaterally, there's that apical tumor, or if it's pneumonia, there's a fractured humerus. So these are sort of classic mistakes, and everyone is susceptible to this. But search satisfying can happen in the more physicianly specialties too, when you find a single pathology, when you tend to stop. You've made one diagnosis, but do you pick through all the rest of the blood tests to find that they also have some secondary, related or unrelated problem? So that's a common one. A second one that I encounter a huge amount in my practice is diagnostic momentum. So I really like this. It's a very evocative kind of name, isn't it? That labels are sticky, and diagnostic labels are very sticky. And if someone has labeled your patient as an pneumonia or what have you at the front door, that has its own intrinsic momentum. And by the time you pick up that patient, there's a tendency to accept that more often than not. And this is really compounded if you're junior, so you're tending less to challenge the more senior opinion. Or if it's something that's, you're maybe not confident in, or it's not your direct field of expertise. And it can be several days later, weeks, years later, until someone comes along who's just that bit suspicious and cynical enough to kind of go back and revisit these labels. And patients can come to, huge amounts of harm from that, both from the missed initial diagnosis, but then from all the, unnecessary treatments and what have you. I see it a lot because I do a lot of consult work at the moment. So when you're coming in as a fresh set of eyes, which makes it a lot easier cognitively and politically, to be honest, to challenge these kind of diagnoses. So it's a really common one. And then maybe a third one, just because good things come in threes, one that I am personally very familiar with as well is availability bias. And I think this is quite common too. And this is simply that, if something has happened to you recently, it's going to be in the forefront of your mind, and you've got a tendency to reach for that diagnosis more than you should. So particularly if it's been traumatic, if you've missed something that's upset you, a ruptured aneurysm or what have you, that's a really emotionally charged event. It's really going to weigh in your mind heavily. And what's going to happen is, this has been shown in the literature, that you're going to be reaching for that CT angio. You're going to be doing those tests. You're going to be thinking about it more than you should. And you're going to be ordering potentially inappropriate tests, putting people through things that don't need to be put through, radiation and so on, all because you now have gained this bias where something is now readily available to you, even though, really it shouldn't be, and it should be integrated more neutrally into your kind of schema. So those are three, but, as you mentioned, Crosscarry, he's fantastic cataloging of these things, and it's well worth a read, because I think everyone's personal practice is going to have a different proportions and importance for these sorts of biases.
Absolutely. Thank you, Owen. And I can attest to the search satisfying bias in particular. So much of my career actually was in Department of Pediatrics, and fever without source is a huge challenge for many of our pediatrics residents, in particular in those days. And you found a little redness in the tympanic membrane in the left ear. That was the source. It didn't matter. You didn't really have to look much further than that. So that's just one example of it. But as I like your other examples as well. So before we talk about your own work, perhaps could you comment in general about what tools, what strategies have been used to mitigate cognitive bias in diagnostic decision making?
Yeah, so it's a reasonably nascent field in medicine. So this has been, on the minds of kind of military and aviation and business as well. But it's only the last couple of decades that we've been engaged enough to try and create interventions here. So there's not a huge amount out there. And the evidence, to be honest, is mixed for pretty much everything. And that's for a lot of reasons. It's because bias is difficult to measure. It's because it's probably very difficult to intervene on, but also something that I've unfortunately come to learn is that it's very difficult to study humans and doctors in clinical practice. So a lot of the things people have attempted are there's a huge variation in the quality throughout the literature. So things that have been tried, education. That's the first thing that everyone's going to think of. I love education as well. The reality is that actually it's had quite mixed results, and a lot of that is to do with how you deploy these sorts of education. So if you're just running ad hoc education sessions, you grab some students and you pull them into the ED and give them some teaching, and people have done trials of this. It fails, which is not massively surprising. It tends not to improve their ability to solve case series. Whereas if you integrate cognitive bias into a more formalized curriculum, particularly for more senior people, who have already sort of overcome that initial dramatic learning curve of getting their clinical skills up, it tends to be a bit more useful for them, and they tend to be better able to solve cases. And you can see that, solving a case is not the same as practicing medicine in real life, but this is where we're at in terms of trying to show that things work. There's a lot of novel interventions that have been tried, using gamification and using kind of mock interviews and mock patients, and people are enthusiastic, but the evidence isn't amazing. Forcing strategies are basically anything that forces you to consider things. I'm not going to say against your will, but forces you to think about things just in case you weren't going to. And the obvious example there is a checklist or a mnemonic or something like that. And, you know, I have a natural repulsion to checklists and paperwork and bureaucracy, but I have to admit, you know, there's actually good evidence for these things when used as a precision instrument. So, for example, the surgical checklist pre-theatre, useful, demonstrably good at reducing errors. I think there's some evidence for cardiovascular exams and ECGs. They work, they help. Whereas unselected take, front door medicine, A&E checklists have, you know, basically no place there. It's just, there's too much to do. And then, you know, maybe the final thing to touch on is metacognition. So actually, the best evidence for mitigation probably comes from this idea of metacognition, which is thinking about thinking. It's just a fancy way of saying that. And we're going to do a lot of this naturally as you get, you know, more experience. And that's asking questions of yourself and others, like, what else could it be? What if I'm wrong? Why do I really think this? Does everything fit together? These kind of basic questions that you encounter in your practice, the reason they work and the reason they've become embedded into our culture is that they force you to stop and confront your own thoughts and your own ideas. And that's probably the best supported approach to mitigating bias, actually.
That's interesting, because I think that in medical education, we often ask students to do that. We'll get them to process their own thinking and to think about other alternatives, and residents as well. Sometimes as attending physicians, we don't do that ourselves. That's just which is quite distressing. So I want to turn a little bit about to your own work. And I did read your paper in BMC Medical Education about the cognitive forcing tool. And one of the reasons, Owen, I wanted to invite you is not, and you had pointed out by email that it didn't show dramatic results. But can you talk a little bit about the aims and perhaps the challenges of doing this sort of research that you encountered?
So, yeah, so I mean, my background is a much kind of more binary sort of science. And I, in my naivety, thought, you know, I'm really interested in bias, love education. I'll just bring some of that sort of rigor to this field and it'll all be great. And it was a hugely challenging endeavor, actually, and it really humbled me. And the challenges are that it's very, very hard to create something that's generalizable to real life, because if it's a bit like a drug trial, if you want to show a drug works, you have this perfect patient population with the perfect disease, and you know, you power your study accordingly, and yet so many of those drugs fail in real life because people don't take them and so on. And it was kind of the same dynamic that I had began to encounter, that it's very hard to show that people are using this tool. It's very hard to measure the bias afterwards, and it gets, you know, the bridge to translating that into the real life in the wards starts to become increasingly difficult. And I think that's why a lot of the field has failed to demonstrate efficacy. So, you know, hard to measure, hard to implement, and hard to translate is kind of the holy trinity of problems there. You know, what was I trying to do? I was trying to make a tool that was generalizable, so that it wasn't targeting a specific bias, that it would cover a few, and that you could just kind of apply to any scenario. And I think that was very ambitious, probably too ambitious in retrospect. The tool I developed was a cognitive forcing tool. That was where the evidence was. So this was basically pulling all of the best examples from the evidence and pooling them together. So, you know, slow, it's a mnemonic. It does what it says on the tin here. It makes you slow down. That's half the battle, because that's what actually a lot of the best evidence is for. Slow down and you will take your time and make less mistakes. But each of those letters also, I think each stood for like a triggering question. So, you know, the S was, are you sure? L was, you know, look at the data. O was, what's the opposite? And W was, what's the worst case scenario? And, you know, each of these, there's a little string of references for each one. So I thought, yeah, this is definitely going to be excellent. And when I piloted it on real people, sitting next to them, tapping them on the shoulder and pointing to each letter, it actually did seem to work. So I had this kind of encouraging results. But in real life, when you ask people, when I kind of pursued the trial and people were doing this of their own accord without me sitting next to them, it's hard to show. And I suspect people didn't really work their way through these things. People skip checklists in real life all the time, and even more so if it's you know, something new and slightly odd. And you know, so that was the idea. That was a tool. It was very much an evidence-based, as much as the evidence is, approach. But I think I encountered every hurdle I could. And you know, ultimately, what I ended up finding was that it didn't. So what I found was that actually people were much worse than I expected in terms of their ability to answer cases. So the rates of bias were just massive. So they were failing miserably in the cases, which was a problem in terms of powering the actual tool itself. But as well as that, it didn't really seem to make a difference. And my suspicion here is that people don't engage unless you're sitting next to them, tapping them on the shoulder, which isn't their fault. And I think that means tools like this are aspirational at best and not very pragmatic and realistic, to be honest.
Do you think, I just want to stop you, do you think people were using the tool without formally using it? In other words, they were processing it in their minds, and perhaps that explained the lack of effect that you found?
Yeah, I think
That's
so.
a tool, yeah.
Yeah, I mean, I think when I ran the pilot on 20 kind of doctors around Edinburgh at the time, I made them think out loud. So as they worked through the questions, I asked them, because I was recording and as part of a sort of a qualitative arm to try and understand the structure of the thought itself, I asked them to talk through it out loud to me. And you could hear them, as they said, well, what's the worst case scenario? And they'd say, well, actually, the worst case scenario is a PE. So maybe I will go back. And whereas I think when you don't articulate out loud, when you don't vocalize and crystallize out your ideas like that, when you're just processing in your head, I suspect that would have been an important part of its of the lack of efficacy when people were doing it on their own in an unsupervised way. Yeah.
All right. Okay, well, thank you, Eoin. I think we are at 7:54, and I promised everyone we'd have about 5 minutes for questions and comments, and then I have a couple of announcements afterwards. So let's open it up to the group. I see some chat questions. Maybe we'll just go through those first. Dr. Atchison, Dr. Solomonides, there are two other contrasts that may be brought to bear in the thinker-doer dichotomy and inferential reasoning model building debate. Do you recognize these from your work? Did you have a comment about that?
Don't have much intelligence to say here other than that, inferential reasoning and model building, I've seen it lumped into this kind of type 1 and type 2 paradigm, and generally it's that's building models, and inferential stuff it's much more detective sort of work and tends to be in that type 2 deliberative thing. So it's not, these aren't prescriptive labels. Like however you approach it, and it tends to be for doctors this kind of hypothetical deductive way where you have a hypothesis, you test with blood tests, you're wrong, you come back and circle that. So there's different ways you can approach it, but the fact is you're doing it slowly, thoughtfully, and the actual structure and the labels I think are interesting but less crucial.
Okay, and Dr. Atchison has an interesting question that I was wondering about as well. And she asks, does a system that encourages speedy clinical work also encourage cognitive errors? And that's one thing I've always wondered, especially in a busy setting. Do we get sloppy in terms of our diagnostic decision making?
Yeah, we do, definitely. So I think it does, to answer the question briefly. For many reasons. One is that the sheer speed means that you won't be in that type 2 thinking, right? So you're more vulnerable to bias to begin with. The other thing is that, working quickly and working at high volume, it massively drives up the decision density that you make. And like, there's pretty good data that by the end of a shift, the quality of your decisions they're pretty rubbish, actually. They're pretty poor after 12 hours of work. And, if you're working fast, by the time you get the end of the shift, you've seen a lot more, you've made a lot more decisions, you're just much more vulnerable than if you were taking your time. So, and as ever, there's a balance. I'm not for 1 minute suggesting that we amble through the day drinking coffee at every bedside. But I think the role of the expert and the skill of the expert is knowing when to stop and convert into that more deliberative and say, hang on, this doesn't quite add up. And, start looking for red flags and orange flags.
Thank you. Okay, any additional questions or comments from our group this morning?
I have a question. This is Julie Keller. This seems kind of like the conclusion we're reaching for right now is that things are kind of bleak in terms of medical decision making. Am I being overly pessimistic? Did I miss anything?
Maybe I'm being overly pessimistic because I don't really think they're that bleak. I think we need to be very thoughtful about how, if we're going to do research and try and prove things work in the most academic sense, we need to be very thoughtful and not, we need to be in type 2 thinking. We can't just design these kind of ad hoc trials because we're probably continually to fail to show things. But I'm very bullish on the idea that we can change and improve the quality of our decisions and the quality of diagnosis. And I think there's two brilliant ways to do it. One is what you're doing right now, which is focusing on the clinical problem, the clinical question, and zooming in on, unintentional weight loss, just like you're doing, and trying to identify what the biases common to that problem are. And I think that's not something I did and not something I've seen a lot of. And then the other way is actually just taking a much bigger step back and looking at the proximal causes, right? So if tired doctors make more mistakes, we should be, as a system, trying to have less tired doctors, putting more people on the floor, having more breaks. And can you demonstrate in a very robust way that that's going to improve bias? I think it would be very hard to do that, but I think you'd be crazy not to think it will probably improve it. So I don't think the future is bleak. I just think we need to be thoughtful about how we invest our energies, and thoughtful about, if we're trying to make it systematic and academic, then make sure that's worth it.
Okay, thank you, Eoin. Thank you, Julie. Any final thoughts? Maybe we've got time for perhaps one more question or comment.
Yes, I would just have a kind of comment and a question. I really appreciated the way that you interwove the ideas of verbal expression, communication, and relationship, even between members of a team who perceive themselves being in a particular hierarchical relationship, like the resident and the attending, or the new attending and the old attending. And I just wanted to ask you how you would go about gathering evidence that there are particular places there that we should focus, that we can think that decision making is just about our rational capabilities and our education and our bank of differential diagnoses and so on. But you really have pointed out that there are so many different aspects that may be difficult to quantify, measure, or even to get people to talk about or to acknowledge. And I guess I had just wanted to hear your thoughts about the complexities of what you've told us today.
Yeah, I think you're asking like such a good question, and I don't think anyone has a great answer, but I think that's the line of thinking that we need to pursue, because we know that when our vulnerable times in terms of mistakes, it's handovers between teams, handovers between shifts, interpersonal communication. Horizontal flat hierarchies tend to be, they tend to be better, just nicer to work in, but better communication. Your juniors pick things up and the seniors pick. So I think intuitively we all see that that's a problem and that those relationships are really key. How do you demonstrate that and that it's worth changing? So again, this comes down to, how pragmatic should you be when we're trying to make changes here? Is it important that we publish a paper and demonstrate these things with a p-value and all the rest? Or we could spend decades, to be honest, trying to nail that one down. Or are we just going to sort of maybe do this kind of mixed methods analysis, get some qualitative, get to talk to some team psychologists, get people from outside of medicine to see team dynamics, and just start making changes and seeing if it improves things? There, it's a real challenge, because how do you measure the improvement after you've made these changes? And I really struggle with this, because I'm in two minds, as you can see. One is just to do stuff to change the system for what I think is the better, but the research part of my brain balks at that idea, and I really want to show efficacy at every stage. And that's why we're all here. That's why we're having these meetings, and that's why we're kind of inching forward with this.
Great question, Dr. Marsh. Thank you so much, Eoin, for joining us. Very, very late in the evening for you as well. So just a couple of announcements before we wrap up. So next week, Dr. Bobby Hughes and I will have a discussion about chest pain in emergency room settings and what a challenging problem that can be. So please do join us for that as well. The other thing I wanted to point out for all of you who have joined, and many of you come from different disciplines, is that we have applied for continuing education credit for physicians and for nurses, and that is still pending, but should be available for you within the next couple of weeks or so. So it's an added incentive to join us on Friday morning. So thanks, Eoin. Take care, everyone, and have a wonderful weekend. Bye-bye.
Thanks, guys.